Welcome to the PA is In, the show created by PAs for PAs, where codependency with your supervising physician is a thing of the past, optimal team practice is the future, and physician associate has taken the place of physician assistant as the professional title of choice. I'm Tracy Bingaman, and I'm obsessed with redefining what success as a PA looks like and what it feels like. Here you'll find the mindset shifts, systems, and processes I use to escape healthcare burnout and integrate my work into my life. Work-life balance is a myth, and an integrated life where you thrive professionally, not a balancing act, is the goal here. My mission is to help you to grow into a unicorn PA who loves their job, has abundant energy, time to spare, and work-optional financial freedom. The PA is in. Should you do a fellowship? How can you break into an area where you don't see a lot of PAs represented? How to become more comfortable with complicated procedures and doing things like running codes. Today, our guest on the PA is In is talking all about her experience as a PA working in the NICU. She pivoted from adult surgery into the NICU after finishing a fellowship, and she's here today to talk to us all about that transition. Lex Mastro is a PA who is going to share her passion with the NICU and her experience with fellowship and give you some encouragement that you can do pretty much anything that you set your mind to as a clinician. Lex, welcome to the show. Thank you so much for being here.
Tracy, thank you so much for having me. I'm excited to be here today.
I am so excited to unpack some of these topics. These are a lot of things that we haven't talked about before. So before we dive in, tell us a little bit about you and what you do.
Absolutely. So I am a neonatal physician assistant. When I had graduated from PA school, I initially started practicing in an adult surgical subspecialty, and then found myself at a recruiting event where I was chatting with another PA who told me that she worked in the NICU. And I was like, the NICU? So like not the neuro ICU where I work now. And she's like, no, the neonatal intensive care unit. I went and shadowed her one day and I loved it so much that I changed my whole career path. And ever since then, I've been working in the NICU. And so I've worked in many different NICUs, all for the same large health system. So I've worked in both small community NICUs and I've worked in large academic NICUs, attending high-risk deliveries, admitting patients into the ICU, rounding on them daily, everything on their daily care from, writing total parenteral nutrition, managing their vent settings, titrating their pressors, to providing bedside sedation when they're having bedside ORs, and including putting kids on and off ECMO, the good old extracorporeal membrane oxygenation. So it's been amazing. I love working in the NICU. I love doing transport. I think the NICU is such a magical place.
It sounds incredible. And I feel like two things, like this sounds so similar to taking care of adults in like a surgical ICU setting. And I'm also imagining it's completely different than taking care of adults. So tell us, when you were like, hey, I was working in an adult surgical subspecialty, what steps did you have to take to get into and feel comfortable taking care of teeny tiny NICU babies?
Yes. Well, as you may remember, we don't learn a lot about the NICU in PA school. And so I had actually attended a year-long residency program, so postgraduate training program. Some places call them residencies, some places call them fellowships. I feel like typically it's about a year long of training. Some programs are a little bit shorter and some are a little bit longer, but most NICU postgraduate training programs are a year long. So I invested a year into myself and learned how to work in the NICU. And through a mix of clinical things and didactic things, just learning how to take care of a baby, because the first thing that you need to know is what is normal. So that way, when something abnormal comes up, you recognize it. And then learning all of the complex critical care management that goes into that. And then when I finally finished fellowship after a year, I was offered a full-time staff position to stay on. And I continue to learn every single day. Yeah.
Yeah. So when you say you invest in yourself, do you pay tuition for a residency or fellowship, or do you accept lower pay in exchange for education?
That's a great question. It depends on where you're going to train. Um, some centers will pay you a staff salary, which I think, in my personal and professional opinion, is probably the best case scenario because the institution is investing as you, as someone that's investing in the team. And so they pay you a full time staff rate to train for them for a year when you then agree to stay on and join the staff. Um, some places will pay you a resident salary, which is a lower salary, typically somewhere that's comparable to medical training like residents or fellows. And typically you don't pay any tuition. Many times a lot of that didactics is provided for you. A lot of programs will have additional things like, continuing medical education money that they'll use for books that they recommend, or at the institution where I work, we have different types of CME that we offer throughout the program. And so by the end, you might come out with 100 credits and say, wow, that was a big investment in myself, but then also helps with my, ongoing licensing management, things like that.
So, what advice do you have for someone who's listening who is thinking, how do I know if a fellowship is right for me, if it's necessary? Is this something that I could just get a job? Like, I am 12 years into my career and have never had any formal training after graduating from a PA program, and I feel incredibly competent. I also don't work in the NICU. So I feel like this is very different depending on what specialty you're in and where you are. So can you help us to, like, if someone's listening and they're trying to decide, is this necessary? In what spaces would you say that this was definitely something they need to do?
Yeah, so I think it depends on how specialized your subspecialty is. So I think something like the NICU is uber specialized. And so I think going back to do time to train and be really intentional about being a provider, I think is super important. I think that, I lecture at a lot of PA schools. I talk about fellowship programming. And I think, a lot of people will ask me, do you recommend this for new grads? And I always say, yes, absolutely. Because when you first come out of school and you're trying to figure out, what is my scope? Where am I going? Because you want to support people to become autonomous and be able to come up and practice at the top of scope. So I think fellowship training gives you a really structured way of onboarding and doing that in a way that supports anybody that joins a team, right? Because anytime you change teams, you're a learner, even if we're not technically traditionally still in training. But even somebody as me, I worked in clinical practice and then decided to go back and do fellowship training and go into another, like, a learner type role or training type role. And truthfully, I don't think that I could have worked in the NICU without having done that. I have a lot of friends that also work in, fellowship programs and other pediatric subspecialties. And I think, many of us feel very similarly that if you want to get somebody in, you want to get them feeling comfortable, knowing the content area, feeling like they can appropriately give education to patients and families. They know the treatment plans. I think being able to set somebody up for success really just improves not only their practice, but then the practice and efficiency for the whole team.
Yeah, absolutely. This is an area that orientation is something that means something very different at lots of different organizations. So sometimes it's incredibly structured. And sometimes it's sort of like, here you are, come see people, let us know if you have questions. And there's a whole span of things in between those two. So I think, especially if you're someone who's coming out and saying, hey, I don't feel strongly about this area. This isn't something that was in depth covered in my programs, which is a lot of surgical subspecialties, a lot of areas that aren't sort of general. We do, 24, 27 months of training, but we can't dive deep into every single area that PAs are working. It's just not possible.
Yeah, because I think many of us, right, we're traditionally trained. We're all trained as generalists. Typically adults, not pediatrics, mostly primary care, preventative medicine based. And so when you find yourself in some of these subspecialties, you really have to take time to look and see, what is the evidence-based practice? What should I be doing? Because at the end of the day, we all want to provide safe, quality care, but you have to do that with some kind of guardrails. And I think having a structured onboarding program can be really helpful for that and set you up for success.
Absolutely. Now, I feel like that general training, that preventative medicine, that sort of like we're going into primary care, that's the need that we once filled, 50 years ago when the PA profession first started. Is there any part of you that was like, when I step into this space and do this fellowship and do this training and become a NICU provider, that makes you worried about what if one day you wake up and decide that you don't want to do this anymore, that you feel like you wouldn't be able to go get a job taking care of adults in primary care or adults in surgery somewhere else?
I feel like I could. I think the likelihood that I'm going to wake up tomorrow and not want to work in the NICU is very low. The NICU is a very specialized place, but I find it to be incredibly rewarding, and I think can be a very miraculous yet challenging place. But I think, yes, sure, I could go back and practice adult medicine, maybe even in another subspecialty if I really wanted to. But I think knowing that I'm really invested in my career and where I am now, especially because I did take all the time to go back and do fellowship, and I've continued to really, do more continuing education, making sure that neonatal medicine is really at the forefront of my practice, I think keeps me where I am now. And truthfully, I think makes me a valued member to practice autonomously in the medical team.
Yeah, for sure. And I think that, if you're weighing this decision, fellowship or not, if it's a specialty that you don't feel like that about, maybe it's not worth it. I mean, I do think that there's some great benefits, but if you're like, oh, I'm going to do urology for a couple of years and then I'm going to move into something else, committing a year to a fellowship in that situation might not be a good investment. So think about that if you're out there like, is this what I want to do and something I see myself doing for a significant chunk of time?
Yeah. And I would say for anybody, if you're even considering it, you can always look at some of the online resources. There's an association of postgraduate physician assistant programs, and you can go in and you can search any program by specialty, by length, by location. You're like, I am relocating to Tennessee with my partner, and this is what we want to look at, and see that I could go and train in emergency medicine or wherever. So I think it's also good to kind of put feelers out into the world and see if you don't have a particular area that you feel a strong sense of purpose. It might be a good way to take stock in what you want to do next.
So I have like a strange fascination with the NICU. So I want to know, like, what is a day in the life? Talk to me about your schedule and shifts, and what are the things that you're doing day in and day out in the NICU as a provider?
Yeah. Well, so many of our shifts in the NICU are 24-hour shifts where we are in-house on call. And so most times you come in the morning, you get sign up from the night team, you do some pre-rounding on the patients that you're going to have for the day, and then you do bedside daily rounds. So every single patient in the ICU you round on, you typically make a plan for the day. You present that plan on rounds to a multidisciplinary team that normally has an attending, the bedside nurse, a clinical pharmacist. Sometimes we have a clinical nutritionist that joins us. And we go through and we do this for every single patient, and we talk to every single family. And so hopefully most times the family is there. And if they're not, we call them and we say, hey, we're going to do rounds. We're just joining, making sure that you guys know what's happening for the day. But you go through that, and that takes a little while, especially depending upon what the census is and the acuity in the unit. But typically after that, you're doing exams, doing any procedures that come up in the unit. I think this is one area of critical care where we get to do a lot of procedures independently, which I think is really exciting. So, if you have a patient that is clinically decompensating and, you're going to run a code and you're going to intubate and you're going to place a central line and do those things, those are all things that I would do as the PA on the team. We get called to deliveries throughout the day, which is always exciting. Deliveries are one of my favorite things to go to. I always try to remind myself, especially when I have students that come and rotate with me, many babies are born healthy in the world, except for when they're not. And so thanks to the neonatal resuscitation program, we kind of know what to do with that. So that's very helpful. And And then eventually we sign out to the night team, which is normally just an attending that comes on to stay in-house with us at night, unless it's a community site in which you are the only provider in-house for all things that happen, good, bad, and otherwise. And then you field calls overnight. You continue to, do whatever the unit needs, admit babies. And then where I'm currently working now, we have a transport team, a dedicated neonatal transport team. And so when we have calls that come in from other community sites, we go out with the transport team to another site and stabilize a patient and bring them back. So that can always be very exciting.
I was so excited to hear that AAPA had upgraded their signature job board, PA Job Source, into an interactive map-based system that allows you to literally zoom into your targeted geographic region and communicate directly with PA employers. The PA Job Source map connects you to the entire landscape of PA jobs. They've got 50,000 PA employers and counting. You can follow a geographic market or employer site and receive alerts when new jobs are posted. You can even send a DM to that employer you've had your eye on for months. But here's the best news. PA Job Source is still completely free to AAPA members. Log in today to map out your future at aapa.org/PA Job Source. Yeah, it sounds terrifying and exciting. Like, I think it's terrifying because I definitely would not be competent to clinically do any of these things. So I feel like I'm like, don't call me, right? I don't want to be the one doing that.
But listen, Tracy, if you want, you could consider going back to do a fellowship and then you could come work in the NICU.
And Lex does not actually live that far from me. So that's like not out of the realm of like reality. Like, we have met in person. So hey, who knows? Maybe that's my next move.
Yeah.
I would love to know, like, how, I know it's probably census dependent, but how many patients are you sort of like the primary person or carrying on any given day?
It depends. We have different teams that are higher acuity and lower acuity. If you're running on a lower acuity team, you typically have more patients, typically not more than 12, sometimes as high as 15. But if you're rounding on a higher acuity team where you have vented patients, in places where I've worked where we have patients that are on ECMO and we're managing those ECMO patients, you have anywhere from 6 to 8 patients, rarely sometimes 10. I think the one thing that we didn't really cover was, in addition to NICU coverage, sometimes we'll cover the newborn nursery and see healthy, well babies, which I think is always fun too, when you get to meet, new families and parents going home with new family additions. And so that can be kind of anything. You could have 5 babies in the newborn nursery, or you could have 25 babies in the newborn nursery.
That sounds like a lot of babies. As someone who's been like solely responsible for taking care of one baby at a time, like 25 babies, I know it's different. Oh my God, that's so many babies.
Yeah. Well, people say, it takes a village. It doesn't matter if you're inpatient or you're at your house. It takes a village no matter what, because the babies, they'll gang up on you. There's power in numbers. So you really have to have people to take care of them.
So cool. Do they call you to every delivery, or only deliveries that they're concerned that they're going to need you?
Only deliveries that they're concerned. So if there's some sort of an identified high-risk pregnancy, we're called to those. Preterm deliveries. Most cesarean sections, just because it's a little bit more high risk that you're being delivered via cesarean versus a vaginal. And then sometimes you might not anticipate anything goes wrong. And then, in the final pushing, have a baby that comes out, or you're having a hard time getting out. And so they'll call us emergently for things like that. And we typically will respond to those, deliveries or obstetric emergencies. And we are normally the person that's running whatever that neonatal resuscitation is.
Yeah. So this is a little bit more general, but just because you're in a field where you're doing lots of interventions, lots of procedures, it sounds like you are the captain of the ship in terms of, codes and resuscitations in those situations. What's your advice for someone who is like, I want to be better in high stress situations. I want to be more comfortable with some of these more complex things, but I'm not that confident in my own abilities yet?
I would say that practice makes perfect. I know we run a lot of simulations. So I think simulation is really helpful. Looking back at whatever the evidence-based practice guideline is for your area of resuscitation, we have NRP. If you're doing pediatric resuscitation, you're using PALS, just like we would use BLS and ACLS. And then obviously some trauma variants, but feel really comfortable knowing what the algorithm is, knowing what the next steps are, and then doing simulations and doing team-based simulations, I think is really important, especially when you are the person that is the leader. It's, the only thing that you can invest in is yourself and your communication skills and your ability to just be calm. Because when you come in and you set the tone for an emergency, everybody else picks up on what you're putting down. And so when you come in as a calm person and you're going to run the code and everybody has their assigned role, you're making sure everybody feels comfortable with that. It's more about assessing kind of the situational awareness than it is about one particular thing.
Yeah. Yeah. And I feel like when you're new in those situations, it's exceptionally hard to feel calm in a high pressure situation. But if you've done it, 10 times this week, it doesn't feel so like I don't know what I'm doing. I don't know how to set the tone, but practicing, again and again.
Yeah. And that's, I think, why, in something like the NICU where it's very specialized, investing in something like residency or fellowship where you have someone that every day you have somebody that you're precepting with, you have a mentor that is, following up with you, debriefing events like that. So you can look back and say, hey, this thing happened. What went well? What did not go well? What would I do better next time? Because I think every patient interaction you have, whether it is a code situation or it is an everyday thing, you're talking to a family about feeding difficulties, something that is not necessarily life and death right then, but is so important to that baby and that family. To them, that is the most important thing in their life. And so learning from all of those interactions so you can be a better provider next time.
Yeah. And having sort of the insight and taking the time to say, even if it's not like formal, with a colleague, you're driving home from work, you had an interaction that was maybe challenging or maybe didn't quite go the way that you wanted it to, thinking like, what could I have done differently? Because we really can't control what other people say or do, right? But as the person who is sort of in charge of those interactions and getting people on board with the plan or really figuring out what they're concerned about, having a debrief process where you sort of think about like, what could I have done differently in that situation?
Yeah, I think self-reflection is really important, and just making sure that you kind of have your own emotional stock of where are you? Because some days, sure, you're going to show up and you have a lot of other things going on. But when you're in the walls of the hospital, especially somebody that does inpatient critical care where you are the person that is answering the call for emergencies, you really want to make sure that you are present, you are ready, and you are mindfully, going to take on whatever happens.
Yeah. Yeah. I mean, this is why healthcare is so stressful. This is why, it's an area that's fraught with people who are feeling burned out and compassion fatigue and like they're overwhelmed because it does take so much of us to be focused and on. And, when an accountant has a bad day, no one dies, right? It's like, it's really, really heavy. And knowing that means you have to sort of prepare yourself for that.
Yeah. And I think a lot of that goes into self awareness, situational awareness, just being really mindful about emotional intelligence, and just looking at every interaction that you have, right? You could be having just, a conversation with the bedside nurse of one of your patients and learn something that is so critical in that moment. She might just be telling you that the baby had blood streaked stool. And that immediately to you is a huge red flag. And you're worried that, a baby could have necrotizing enterocolitis. And all you said was, hi, how are you? And it's like, you got to have your ears up and ready to go at all times.
Yeah. Yeah. I feel like there's this balance between like paranoia, right? Where we're always like, worst case scenario, like what's happening here? And like thinking everything's fine. And like you have to be like, I'm just sort of assuming everything's fine, but I'm always a little suspicious that something could be going wrong.
Yeah. Yeah, I think anyone that works in a critical care sector or some sort of a surgical subspecialty, I say the babies, they are unwell until proven otherwise. I always assume the worst and have at least 10 backup plans until they have proven themselves.
Yeah. 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 And I think that that's something as a clinician that we hone over time. Like I can remember as a student, um, I absolutely despised my ER rotation. It was early on in my clinical experience, and I didn't know who was sick and who wasn't sick. I didn't I didn't have a good understand I mean, I knew how vitals worked, right? But I didn't like now I could walk through the ER and be like sick, sick, well, sick. I just would have a feeling about someone about whether or not I needed to be worried about them. Like I would have surgeons say like I don't trust this one and I would be like I don't know how to get to that point where I can just know I don't, I'm like, I have to keep a close eye on this one, or and the nurses will say, like, I'm worried about this one. And you're like, why? And they just say, I'm concerned.
Yeah. Anytime a nurse calls me and says, I'm concerned, I immediately drop everything I'm doing. I'm like, if you're concerned, I need to be concerned. And if I'm not concerned right now, I need to get concerned.
Yeah, I wasn't until you said that, but now I am.
Yeah. Yeah. I always, with precepting a lot of students and having a lot of PA fellows that come in and train, I tell them, you don't know what you don't know. And that is the thing about any new area of practice. You don't know what you don't know. And so you need to have a lot of healthy skepticism and be humble. I'm humbled every day by babies. I get a blood gas and I think, wow, what the heck happened here? That's not what I was anticipating at all. And you got to roll with it and be flexible and adapt.
Yeah. So I'd like to talk a little bit more about emotional intelligence. This is something that's sort of come up in passing in a couple of interviews that we've done. I think it's something that we don't cover in school, like that we just don't. No one is quizzing us on this. There's no multiple choice question on the boards about it. And so we have to develop that ourselves as clinicians over time. So what is some tips that you have in terms of how we can be better about our own emotional intelligence and interacting with colleagues and patients and families?
So I think everybody should read about emotional intelligence, especially if you're unaware of what that is. So if you're listening to this podcast right now and you think to yourself, emotional intelligence, am I just like thinking about my emotions? No, this is a whole thing. So I would immediately take stock in Googling emotional intelligence. There are many books out there that you can read. I read Emotional Intelligence 2.0. I found that to be really helpful. When I moved into a formal leadership role, I read Emotional Intelligence for the team, which I think was really helpful too. But it's all about knowing where you are in your life at that moment in time and being very self-aware. How are you feeling? You're stepping into a conversation with somebody else. How are they feeling? If you're trying to have conversation with someone, are they in a place to receive the conversation? Are you in a place to give this conversation? A lot of people think that when you're trying to disseminate information, it's a monologue, and that's not true, right? It's a dialogue. You have to have two people that are actively ready to go in and unpack something. So I think a lot of it is communication based, but then I think the other thing is just knowing yourself as a person. And I think a lot of that comes from self-confidence, self-awareness, knowing your own implicit bias. I think that is something that is really important for all of us as healthcare providers. Working in the NICU, we see lots of healthcare disparities, both in neonatal medicine and perinatal medicine. And I think knowing that we all have implicit bias is important, and just being really aware of that.
You might not know this about me, but one of my most despised tasks as a clinician is charting. That's why I'm always searching for hacks, tools, and tactics to make charting more accurate, efficient, and less of a huge pain in the butt. If you too want to spend more time connecting with your patients and less time pointing, clicking, and typing into their chart, you should definitely check out Freed AI. Freed AI is a medical scribe on a mission to free clinicians everywhere from the purgatory that is writing notes. Freed AI listens, transcribes, and writes your medical documentation for you. You can even use the code PA50 for $50 off your first month with Freed AI. These notes are written in your style and done for you by the end of the visit. Can you imagine what it would feel like to leave work on time, notes done, without having to crack your laptop open in the evening? Freed is HIPAA compliant, completely secure, and it takes less than 30 seconds to learn. Get back to what you love doing, treating your patients, and let Freed AI do the rest. Yeah, I think that is something that is often in the background, but that we don't really think about in terms of our own clinical decision making, our own interactions with people, that it's there. And unless we're really focusing on it, we don't take it into account when we're in these situations. Yeah, for sure. So let's talk about access and healthcare disparities. I imagine that you see a fair amount of this in terms of access to prenatal care, in terms of when people come in, et cetera. So the average person listening to this is not a neonatal provider. Maybe some people are an OBGYN, so maybe some people are sort of tangentially providing some of this prenatal care. But what can we do to improve healthcare access and to, address healthcare disparities inside of our own communities?
So I think the biggest thing is education and knowing where do disparities exist so that way you are even able to be in tune with knowing what that is. And then I think knowing the resources that you have available, because I think, many people work in internal medicine and primary care, and sure, some subspecialties that may see pregnant people in various areas. But I think the first thing is addressing access to maternal care because we have many maternal care deserts. I know that there's a big push right now trying to grow advanced practice for pregnant people. So certified nurse midwives, doulas, who are not technically clinical providers, but provide a great deal of psychological, emotional support to pregnant people. And I think knowing that really sets the tone because you can't identify a high risk pregnancy if a high risk pregnancy does not have prenatal care. We have plenty of people. I'm called to many deliveries, and the reason that they called me was no prenatal care or limited prenatal care. And it's like, okay, yeah, I'm on my way. I'll be right there. And afterwards, I always make sure to go back and talk to the family and ask them, like, did you, like, where were you at? And how can we better assist you? Because I think a lot of people don't look at the social determinants of health. Why couldn't they access care? Did they not know about a local healthcare center that they could have gone to? Did they not understand, how to enroll in Medicaid? Maybe somebody just didn't have that conversation with them. Or is it a language barrier? I mean, I think there's so many different complex things that go into that. But truthfully, education, I think, is the biggest thing as a starting point. In the NICU, we see so many healthcare disparities for people of color. I mean, we see, truthfully, infant mortality rates for Black babies so much higher than every other subset of patients. And I know this is something that, in the neonatal world, we draw a lot of attention to this. There are entire conferences dedicated to addressing, perinatal outcomes. And I think a lot of Black infants do poorly because a lot of Black mothers do poorly. And, people need to pay attention to that and draw attention to what we need to do to create primary interventions. And I think a lot of people just don't talk about it because it's uncomfortable.
Yeah. Yeah, for sure. It's also one of these things that it's fascinating to think about from a situational standpoint. Like, oftentimes when people deliver, it's one of their first encounters with the healthcare system. So if they're a relatively healthy, young adult, they don't come into the hospital. Like, a lot of people don't stay overnight into the hospital until they deliver. So it's fascinating that this is like the first encounter with the healthcare system, and that's an opportunity to have those conversations and to say, like, why didn't you come in? Right. So, did you not know where to go? Did you not know how to, did you not know that you were supposed to? Is this just something that, is not part of your culture, part of the norm that you have seen other people in these types of situations do?
Yeah. And I think it's most times it is truthfully a knowledge gap. Working in rural central Pennsylvania, many people just don't know the resources that we have. We have many community healthcare centers where anybody that's enrolled in Medicaid, or if you're uninsured, you can go there and you can have all of your prenatal care, your obstetric care. You can even go back and see them as your pediatrician and their primary care. And I think a knowledge gap is huge. Many people don't know the resources that are out there. And so I think looking at, healthcare centers and looking at some of the information that's coming out about healthcare disparities. I know the March of Dimes puts out a report card every year that looks at statistics from the previous year. And the 2024 March of Dimes report card just came out, and it is stark, stark and unfortunate.
So the report card is like of facilities and their statistics?
It looks at all 50 states, Puerto Rico and DC, and it puts out information on what is your preterm birth rate, what's your infant mortality rate, what's your maternal mortality rate, and then does some risk stratification for different disparity ratios, looks at factors that impacted preterm birth, because many times things like, hypertension, many people think they have gestational hypertension or some sort of superimposed preeclampsia. They've probably actually had chronic hypertension all along, but because they never utilized any healthcare, they did not know that. And so they come in and they have poorly managed hypertension because it's longstanding, which then impacts their placenta, and then they deliver preterm. It's one of the most common things we see. The same with people that are gestational diabetics who are actually diabetics who just didn't have care. Yeah. And so that's why postpartum care is also really important. People come in and they're like, oh, I'm a pregnant person now. I have to see the doctor. I want to come in. I want to see my obstetric PA in my office, or my certified nurse midwife. Pick your provider. But a lot of women, especially uninsured or underinsured, once they get out of the 60-day Medicaid coverage, then they don't seek care. And so I will say the March of Dimes report card also puts out a lot of different information about policy actions. There's a big push right now to extend and expand Medicaid past 60 days postpartum, because a lot of women fall off the radar because you don't have insurance. And so then you don't go back for some of your postpartum checks. And, that's where you see a huge shift in, longstanding hypertension, longstanding diabetes, a lot of issues with mental health and postpartum depression. I mean, a lot of these things, if you don't seek care out and it's not accessible to you, you're not set up to succeed.
Yeah. Yeah. I can totally see that. As someone who has had a lot of babies, I can just, and I am the first person to say, like, I was insured, knowledgeable, like with access and all of these things that set me up to succeed in that time frame. And still, I struggled with some of those things, and I knew where to go and who to see and how to get, what I needed. And also there's a human that I'm taking care of. Like, it's not an easy time, and people are having to get back to work, and there's just all of these factors that go into, you know, it's so much more. It's such a good reminder that when someone gets in your office for an appointment, that you could see, 25 patients in a day, and each one of them had to go through different things in order to get there, right? They had to know that something was wrong. They had to decide that they were going to get seen. They had to get an appointment and get to your office and then tell you about this thing that's like sometimes very vulnerable, right? The reason that they're there. And then if you prescribe a medication or testing or lab work, do they have access? Do they have the time to get that done? So many things outside of the bounds of like, they walk in, we see them, we diagnose them, we do their note, and then on to the next person.
Yeah. And I do think it's really hard to navigate the healthcare system in general, And, that comes from, we both have very high health literacy. We speak a different language than most people speak. And it is so hard. We definitely don't make it easy. And so I think what I would challenge every PA or any healthcare professional listening to this too would be to make it easier for your patients. Like, that's all of our responsibilities, is to meet them where they are. They're not coming to meet us where we are. We're at work. It's our job. We're there to serve. And so I think it's really important to remember that.
Yeah, that's fascinating. I feel like there are reminders of that all around us. Like I can think of like 2 times in the last couple of weeks that like a friend or one of my older kids or one of their friends asked me like, is this enough food in my stomach to eat this to take this antibiotic? Or like I have one son with an EpiPen who called me and said, what happens if you inject yourself with your EpiPen, but you haven't eaten a peanut? And I said, what did you do? And he said, well, I thought it was a trainer, but it's not, And then he said, should I eat a peanut? And I was like, no. And to me, that's just like walking around knowledge because I'm walking around with that knowledge, but I forget that that's not normal.
Yeah, right. Because we live in this alternative reality. It's just like critical care people. We think everybody is so sick. I'm like, yep, you're definitely just in compensated septic shock. You're going to fall apart here in just a minute. Everybody just wait. But it's like that. You're just like waiting for the other shoe to drop. Whereas everybody else, they're just walking through their life. It's just a regular, everyday, whatever. And their stomach is hurt for 3 months. And, lo and behold, they have some, terribly awful diagnosis that they need a really complex, care plan for. And that's the other thing. Like, if you really do actually need to utilize healthcare, it's really hard.
It's not designed. I mean, the system is not designed for ease of use for consumers. And it's also not designed for healthcare providers to be able to help their patients get what they need either. Like both of those things are hard because of the way the system is built and exists.
Yeah. I will say I feel so spoiled to work in the NICU because working in inpatient critical care, we don't need things like prior authorizations. And so I respect everybody on here that has to get a prior auth for something because it's important for that, that patient and that family. And that's why you went through those steps. But, most of my shifts, I work 24 hours. If I need to talk to a family for an hour, I sit down and I talk to them for an hour about whatever's going on with their baby and answer all their questions. And then if they had questions in 15 minutes after I left, the nurse will call me and I'll come right back. Yeah. And a lot of people don't have that luxury. And so I feel so fortunate and so grateful to be where I am.
I loved that about inpatient medicine. Like, I feel like sometimes it drove me crazy that I never knew what was going to happen and I was constantly getting pulled, but also the fact that I could pivot and take care of someone who was sick and get them to the OR and do the things that I needed to do, and then go back and discharge my stable patients who were going home and give them the education, that it wasn't an appointment, like that it wasn't, oh, it's 8:15, it's 8:30, it's 8:45. You're seeing your patients on this specific schedule. Yeah. Awesome. Well, I think this has been so fun and also super informative. So if someone is listening and they want more Lex in their life, where can they go to get in touch with you, to follow you, to learn more about what you're doing clinically and in your leadership?
Well, I don't have a large social media presence. I will say my dog Tuxedo has an Instagram account. He uses it pretty regularly. I have a LinkedIn that I can send you information for, and can follow up and send you some other resources from the March of Dimes and the Association of Postgraduate Physician Assistant Programs.
Yeah, I think those are great. And we'll put them in the show notes. So if anyone has been thinking about fellowship and wondering, where they are and what they include and how long they are, we'll link those so that you can find those. But thank you so much for coming on the show and for sharing your wisdom with us.
Yeah, absolutely. Thank you so much for having me, Tracy. It was great. And I love to spread the good word of neonatal PA. So if you're listening and you want to become a neonatal PA, you can do it.
I feel like we talk a lot on the show about being humans ourselves and that we are imperfect as healthcare providers, but it's such an important reminder that our patients are people and that they may be up against some significant barriers or disparities that are keeping them from getting to us, and that we can meet them where they are and make sure that we are educating and informing them and taking just the best care possible of the people who end up in our exam rooms, in our ICUs, and in our operating rooms. Thank you, as always, for tuning in to another episode of The PA is In. That's all for today. This PA is out. Congratulations, you've just joined an awesome club. By listening to a full episode of The PA is In, you are officially on the Unicorn PA team. Welcome aboard. What most team members do is they subscribe to the podcast because that allows them to automatically get the latest episode of the show. The life of your dreams exists on the other side of taking action. Keep making small shifts and keep getting better. Your life will improve, your career will soar, and you will have the confidence you need to create your own success. I will see you in the next episode. This PA is out.